dear audience. I'm Gabriella Rapszky from the emergency department, and let me introduce you to my PhD topic, which is point-of-care devices in the management of patients presenting at the ER. So yes, I'm Gabriella, and my vision is to improve the management of patients presenting at the emergency department by contributing to the already existing guidelines. I have two ongoing projects right now. In the first one, we were investigating the diagnostic accuracy of rapid molecular assays, and in the second one, we'll be investigating whether a risk-selected method, clot-provided therapy, has an impact on the patient mortality and the number of blood products used. So in the first one, in my first project, we were investigating the diagnostic accuracy of rapid molecular assays in the diagnosis of bloodstream infection. And about the background, sepsis is it can be defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection, and it's a global health issue because it affects many patients, causing 11 million deaths each year. And early management is important because with adequate microbials and rapid resuscitation strategies, we can improve patient outcomes. One of the main disadvantages of the current gold standard, the blood culture, it has a long turnaround time. And to resolve this problem, there are already existing rapid molecular assays on the market, and these assays can be performed on a whole blood or a blood culture sample, but without the culturing step, even less turnaround time can be achieved. So our aim was to investigate the diagnostic accuracy of these rapid molecular assays. You can see here the clinical question, and we included all patients of all age, and for the index test we tried to collect commercially available devices fitting several predefined criteria. And we hypothesized that these rapid molecular assays are non-inferior to the gold standard blood culture. And our clinical implication was to provide faster diagnosis for patients with sepsis. So here you can see the systematic search, which was done roughly 1 year ago with the search key, which resulted in a high number of articles. And at the end of the selection, we included 99 articles in the qualitative analysis and 74 in the qualitative analysis. There were articles with different reporting different units of analysis. For example, patient numbers, sample numbers, or episode numbers. These can't be put together. For episode numbers, the definition of an episode were different in the articles. Therefore, those articles were excluded from the quantitative analysis. And we analyzed separately the articles reporting patient and sample numbers, which you can see the pooled diagnostic measures on in the rock plot. And you can see that there was no statistical difference between the parameters, considering sample and patient numbers. But we can also observe that the diagnostic measures of these rapid molecular assays are quite low. So they can't really used as a rule-out test. And we can also observe that the specificities are higher. We also made a population-based subgroup analysis whether there are differences in the patient population. We can see that the sensitivities are quite equivalent, but there are some differences in specificities. We can see that the yellow one, it's a pooled estimates of patients from the ICU. The specificity is a little bit lower than compared to the population from the ER. These differences, though, were not, after adjusting p-values, were not statistically different. And we also made a device-based subgroup analysis. During the selection, we found 8 different molecular devices which fit all our predefined criteria. We tried to collect all devices which can be used by an emergency physician. So we collected devices with a maximum turnaround time of 12 hours and with a target list of at least 20 pathogens, and which can be performed on whole blood. Of these 8 devices, only 4 could be included in the device-based subgroup analysis due to the low number of articles for the others. We can see some differences here. We can see that the blue dots representing the Iridica bug BSA assay outperforms all other devices. Considering sample numbers, there is also a big difference between the red and the green one. So the Septifus life cycle was higher than the Magicplex assay in sensitivities. And we can also observe the differences in patient numbers. So the biggest differences between the Iridica, which outperforms all other ones, and the Magicplex assay. These, regarding sample numbers, these differences, even after adjusting p-values with the whole methods, were statistically significant. We also made sponsorship-based subgroup analysis, but due to the low number of articles, we could only analyze articles with one assay, the Septifest M grade, but we found no statistical difference in the pooled measures of sponsorship, of articles with sponsorship and without sponsorship. So our conclusion, based on these results, that the Iridica bug BSC outperformed all other molecular assays, and but unfortunately, these currently available rapid molecular assays are inferior compared to the gold standard blood culture. And for the implication for research, we need better rapid molecular assays to be developed as an alternative diagnostic method for sepsis, because yes. Right. So our study has some strengths and limitations. The strengths, well, as from the search key, so the search key resulted a high number of articles because of the broad literature search, and also we had around 11,000 patients, so we have a large sample size, and this is the first meta-analysis analyzing data types separately. But we have some limitations. For example, articles excluding samples which in which pathogens are not on the target list, we included them, and even we included those articles in which they did not report on the handling of contaminants, so it can cause bias. And also a third limitation, that this blood culture is not 100% in real life. It's not 100% sensitive and specific. So currently, the manuscript I will finish in 2 weeks and send to the internal review, and we plan to submit it in a D1 journal. In my second project, it will be a retrospective cohort study. We'll be investigating risk-selected method-guided therapy in patients with gastrointestinal bleeding. Gastrointestinal bleeding's incidence is 33 to 47 per 100,000 population. And of a patient's hemostatic state, risk-selected methods provide a rapid assessment of coagulation and facilitate a more accurate targeting of therapy compared to the conventional laboratory test. There are already existing guidelines recommending the use of these risk-selected methods in trauma patients and with patients with perioperative bleeding, but there is no evidence regarding patients with gastrointestinal bleeding. And our aim will be to observe the differences in the management and the blood products used in patients who receive a clotpro-guided therapy. Our clinical question regarding this project is whether the use of clotpro influenced the management of GI bleeding patients presenting at DED. We would, well, of course, include patients with GI bleeding, and we would compare two groups, one patient group where clotpro would be performed and the other where it wasn't performed. For the outcomes, we would use a composite outcome, and also we would collect the total blood products used. Yes, and our clinical implication to optimize the number of blood products used. So here is a summary of my ongoing projects right now. The planned submission date of the first project is March this year, and the second project is early autumn. And thank you for your attention. I'm waiting for the questions.
Thank you for the presentation. I was just wondering, maybe it's a dumb question, but can you somehow test these rapid molecular assays by just inserting something where you know there are 0 pathogens and just looking at how many sort of these false positives you get? Because to me it's kind of a little bit strange that you could detect something that's not there at all.
Yes. Thank you for your question, Marty. Yes, actually there are studies with spiked blood samples when there are healthy patients. They took a blood sample and they spiked the pathogen, and whether they can detect or not. But in real life there are factors that can impact whether these tests can detect or identify these pathogens, and it can also depend whether these patients receive antimicrobials. That's, for example, one factor that can decrease the gold standard sensitivity. And also, it depends on the volume of blood they are taking. That's correct. But we only included the sick patients in the analysis.
Amplifying bacterial DNA by PCR. And if you imagine PCR, if you do it with water, after a cycle time, it's going to be positive anyway, without any bacterial DNA. They are using PCR method, so it's just depending on the cutoff.
Does the type of the bug influence the efficacy of this test? For example, the detection rate of the gram-negatives is better than the gram-positives or whatever?
Yes, there are some bacteria which are more fastidious than others. So there, for example, well, not of these tests, but for example, for the blood culture, it depends which pathogen you would like to culture. For the PCR-based test, I didn't mention that they actually detecting DNA, which they amplify then. But for the gold standard, it matters what's the pathogen you are trying to culture, because they are unculturable pathogens as well.
Okay, so the gold standard is more influenced by the type of the pathogen than this new test then?
Yes.
Okay, thank you.
Thank you. My question would be, how could this help with the therapy guidance? Because I would imagine that someone there is with sepsis, receives a broad spectrum antibiotics, which is killing anything, and then we wait for the culturing result, and then we target it based on the resistance. Could these new methods give us a hint about the resistance of these bacteria?
Yes, some of these methods can also detect antibiotic resistances, and with that, survival patient outcomes improve by an earlier targeted therapy, and also longer empiric therapy can also have adverse effects. So that's why it's beneficial. Would be beneficial.
Thank you very much.
Thank you for your question.